Let us now welcome Dr. Harathi Bandaru Garu. Dr. Harathi Bandaru ma'am has done MD, MS, FACP, FACG, Neurology in Texas and Internal Medicine from New York. She's a consultant neurologist in Mosaic Life Care in Kansas City, USA, and currently faculty at the American Academy of Neurology. Ma'am is joining us virtually today to speak on neurological emergencies. So let us quickly welcome ma'am. Thank you, ma'am.
Hello, everyone. Welcome to all and welcome to today's seminar. And it's my absolute pleasure to be here, especially all my distinguished professors, teachers, and my dear students. A warm welcome to all. And hello, everyone. A warm welcome to all, especially all my teachers and distinct professors and my dear lovely student. A warm welcome. This is Dr. Harathi Bandaru. I'm a neurologist from Kansas City. It's my absolutely pleasure to be here. So today we'll be focusing on 3 important neurological emergencies, which you all should know, especially after final year, especially when you are going to casualty. It's very important to identify those 3 neurological disorders. And the most exciting stuff after my presentation is whoever answers my questions, they are going to get surprise exciting gift. So please pay close attention to my talk, especially because I'm going to talk about them as I go on with my speaking, but the answer is not there on the slides. So pay attention, it will be very rewarding. Let's start the program. I'm going to share my slides. So today my agenda. So we are going to go over 3 neurological emergencies and we are going to talk about the diagnosis, management, and mostly I'm going to talk about my clinical plus in real practice. Have no financial disclosures and no conflict of interest. Let's dive into the first patient. 68-year-old man with medical history of hypertension, atrial fibrillation presents to the emergency department with sudden onset of right-sided weakness and aphasia that began 1 hour ago. Please pay attention. The symptoms started 1 hour ago and he's alert and he has significant expressive aphasia, right facial droop, and the strength is 2/5. So what do you do next? First of all, what do you think about it? When you look at the temporal profile, all his symptoms started 1 hour ago. What could be so sudden? And then when you look at the presentation, sudden aphasia, cannot talk, and then cannot process, and right facial droop. So what is the first thing that comes to your mind? So that is stroke. So why we need to diagnose stroke so fast? Because if you do not diagnose it fast, time is brain. 1.9 million brain cells die every minute after stroke. So you need to be quick and time is brain. Every minute is very important. So again, the patient presented with facial droop, weakness, and aphasia. So where could be the lesion? Let's talk about basics. I'm not going in detail because I know final year students, it's very important to know about this. When you look at, I'm going to point out with a laser. So when you look here, so the current patient had involvement of facial droop, aphasia, and weakness. So when you look at this image, middle cerebral artery is the area that covers it, right? And then when you talk about anterior cerebral artery, so when you look at it, mostly leg will be involved, okay? Keep that in mind because this point is very important later on for you. So when you talk about the blood supply, you remember mostly middle cerebral artery, anterior cerebral artery, posterior cerebral artery. Middle cerebral artery, typical presentation, facial droop, weakness, aphasia. anterior cerebral artery, leg weakness, urinary incontinence. And posterior cerebral artery, you'll have vision problems. Remember this? This is a basic presentation. Then let's talk about what do you do next. Let's go to the stroke protocol. So whenever any patient comes to the emergency room, you don't wait for the neurologist. As a clinician, whether you are a final year student or a house surgeon, first thing that you need to do is get a CT scan. Why you need to get a CT scan? To make sure the patient didn't have any bleed. So once we rule out the patient does not have any bleed, if the patient comes within the window, within 4.5 hours, as I said, time is money. So if the patient comes early, you can treat the patient with clot busting medications called tenecteplase, alteplase. It's also called as TPA. So when you treat that medication, you are going to bust the clot and you're going to help the patient with great recovery without any residual deficits after all. So that's why it's very important. So lifestyle, life longevity, this is all very important. So you get the CT scan, making sure the patient does not have bleed, and if the patient is within the window, go ahead and treat him. And you don't need, usually ER team will talk to the neurologist and they'll go ahead and treat with the clot busting medication. You do not wait for anyone. Then you will do a CT angiogram, head and neck, making sure the patient whether the patient has any large vessel occlusion or not. Once the patient has large vessel occlusion, you remove the clot through mechanical thrombectomy. So that is the procedure. After you give TNK, after you do mechanical thrombectomy, you need to closely monitor the patient in ICU. Very important. You cannot admit on the regular floor. So you need to keep monitoring the patient. Let's go to previous slide. This is a very important slide, but I'll summarize everything in few sentences. Make sure before you give TNK, make sure they are meeting the criteria or not. Because at the end of the day, you have to do benefit to the patient. So make sure the patient does not have any bleeding problem with him, and then make sure the patient is not on any anticoagulation to reduce the risk of bleeding. In spite of taking all these measures, still we have risk of 4.8%. So make sure you explain the family members about this risk. Next, so once you treat the patient, stroke prevention drugs, they are very important after you treat the patient. So, as you know, stroke is the number 5th cause of mortality. Make sure you treat all the risk factors, hypertension, make sure no smoking, diabetes, cholesterol management, and also identify the cause of your stroke, like cardiac monitoring, making sure you identify whether the patient is a new onset of AFib. If it is a new onset of AFib, then the management changes. You should start the patient on anticoagulation no matter what, because that only can save the patient. So otherwise, if the patient has a regular stroke, not cardioembolic, you can treat with antiplatelets, aspirin, Plavix, and make sure statins should be there. Your LDL goal should be less than 70. Definitely every stroke patient should get echocardiogram and cardiac monitoring. Physical therapy, occupational therapy, speech therapy. Early rehab is the key. That no one can replace early rehab. Very, very important. You have to start as soon as possible. On the right side, you have the techniques of thrombectomy. You can remove the clot through aspiration or stent induce. Okay, so did you ever hear about transient ischemic attack? So do you treat only the real stroke patient who comes with weakness and facial droop? No, you should also treat the patient who comes with transient ischemic attack. What does it mean? So they come with symptoms, but the symptoms resolve within 24 hours. Why do we need to treat the patient? because the 7-day stroke risk is very high if you do not treat them. So prevention is better than cure. So what are the factors? You need to make sure you look at the age, blood pressure, what are the symptoms, weakness, how much is the duration of the symptoms. Look at the table. When you look at the, if score is greater than 6, your 7-day stroke risk will be 35%. That is the reason why you really need to treat the patient. What do you need to treat? As per chance trial, you need to treat with aspirin, Plavix for 21 days, followed by aspirin along with statin. Please educate the patient, and lifestyle modifications. Very important. This is like minimum that you can do as a physician. You do not have to be a neurologist to do all these things. That's why it's important to know and identify the stroke as soon as possible. Okay. Next, move on to the second patient. So, this patient, pay attention, 62-year-old man brought to the emergency department and progressive memory problems, and then 2-month history. It didn't start all of a sudden. 2-month history of progressive memory problems, and he frequently forgets conversations and become more withdrawn. And when you look at the patient, brief, frequent episodes of involuntary posturing involving left arm and left side of the face. What is this frequent? Whenever anything stereotypic, repetitive, involuntary, jerking movements, and when it happens, what should come to your mind? So you should, in this case, I would think, like it say, if I don't know anything about this patient, I would think of partial seizures, right? So look at the other, the episodes are very short, lasting for few seconds and occur dozens of times a day, and sodium level is 128, okay, and head CT is normal. So what do? So as per the all the history, you got an idea, okay, it could be a seizure. Okay, first let's start with whatever you know, right? So before we move on to the next slide, let's talk few minutes about any status or any status epileptical seizures. You know the basic stuff: A, B, C, airway, breathing, circulation, followed by benzodiazepines, lorazepam or midazolam. My favorite anti-epileptic medication is levetiracetam. Phenytoin and fosphenytoin are the last options for me because it has a lot of interactions, especially I deal with a lot of stroke patients. So the fosphenytoin and phenytoin, they are the last option if the patient doesn't respond to Keppra. Keppra means levetiracetam. Valproic acid is also good, and you can also give propofol and midazolam drips. Okay, so let's move on. So pay attention to the history and temporal profile. When did all these symptoms start? 2 months, not yesterday or today. And okay, any illness? Did I mention about any illness or any infection? No, they didn't talk about anything. And the patient does not have any prior history of seizures. They didn't talk about any alcohol use, or so no trauma mentioned about it. So what is it? Okay, let's keep treating the patient first. So we'll get prolonged EEG monitoring, we'll get brain MRI, lumbar puncture. So do we need to wait until we get all these things to treat the patient? No, go ahead and start treating with your anti-epileptic drugs. Then, in spite of starting treating the patient, still the patient is not responding. Then what do you do next? So then you need to think, what other diagnosis that I can think of? Is there something else that's causing this problem? You should always think of etiology that's causing the problem. You should treat the etiology. Very important. So, did you ever hear about dystonic seizure, faciobrachial dystonic seizure? Okay, let's say you don't know about it. Okay, so this appears to be kind of seizure and not responding to the regular treatment. So what else? So go with the clinical presentation. Stereotypic episodes of involuntary posturing of the left arm, which means, Okay, it could be some dystonic seizure. So, what is dystonic seizures are associated with what kind of situations nowadays? The reason that I put this slide is, as a neurologist, I reviewed second. I always get cases for second and third opinion for a review. This is one of the case I reviewed from India. So that's why I thought it's very important I put this case so that we all can understand more about it. So they did a great job. They treated this patient very well. All anti-epileptics are used, but there is no use. So then the clue for it is there is a hyponatremia, right? Sodium level is low, and the typical dystonic seizures, which is commonly seen in LG1 antibody encephalitis. You might have heard about these a lot. Autoimmune encephalitis, they are widely diagnosed nowadays. They're becoming more common, autoimmune antibody encephalitis. So what is the treatment? You don't know the type of autoimmune encephalitis. You don't know anything. But if you suspect autoimmune encephalitis, you go ahead and treat the patient. The treatment is same for every autoimmune encephalitis, IVIG. Corticosteroids you can use. My favorite is IVIG. We use IVIG. It's vital for seizure control, and it is early initiation of this therapy is the key, and it improves long-term cognitive outcomes. So the summary is you need to think of different diagnoses when a typical seizure patient is not responding to seizure medication, and start IVIG early. Okay, let's move on to the last case. And most of these cases you already have seen in your casualty or ER. So 19-year-old college student presents with rapidly progressive bilateral lower extremity weakness. Rapidly progressive. Look at the timing. 3 days ago, that began 3 days ago, and also started as tingling in the feet and progressing to his knees. He reports he had an episode of watery diarrhea and fever about 2 weeks ago. So, preceding GI illness 2 weeks prior, and all these symptoms are very progressive, and last 3 days it's been very progressive. So, the patient has absent ankle and patellar reflex, decreased vibratory sensation in the feet, so but normal strength in the upper extremity. The patient vital signs tachycardic, but as of now he is able to protect his airway. So first of all, when any patient comes like this, you need to clearly examine, and then do you admit the patient or discharge the patient? You have to admit the patient. The reason I asked you this question, one time a similar presented patient comes to the ER, and the ER physician says, oh, you got a GI diarrhea last 2 weeks. Oh, you are weak. So don't worry, it will improve. So the patient got discharged from the ER, and obviously the patient collapsed after going home. So depending upon your clinical presentation, you need to identify which patient is going to decompensate. Make sure you admit the patient. Then the next question is, where do you admit the patient? Okay, so you need to admit the patient in the ICU. Again, please pay attention to the temporal profile, how rapidly the symptoms are progressing. Pins and needle, you can see in 80% of the patient, reduced absent reflexes and cranial nerve involvement or any bulbar involvement. Make sure, because if the weakness is rapidly progressing, what is going to happen? Obviously, their respiratory muscles will go weak. They need intubation. They need respiratory support. So you need to keep that in mind. So again, do you wait for the next diagnostic steps, lumbar puncture, EMG, MRI, lumbar? No, you will go ahead and treat the patient. So let's talk few things about lumbar puncture, because you're going to get the question on this. That's why. So lumbar puncture, did you hear about albino-cytological dissociation? You might have heard about this. So protein is high, but white cell count is very low. Keep that. So EMG, you don't worry about it. Neurology will do that. But early first 1 week, even though you do EMG, you don't see anything. So that's why EMG can be a part of diagnosis, but you do not wait to treat the patient of MRI, lumbar spine, thickening of the nerve roots you can see, but again, you need to start the treatment. So I said I need to admit this patient to the ICU. Why ICU? I already explained. Look at the rapid progression. That's why we do this score, GBS Erasmus Respiratory Insufficiency score. So the rapid progression, especially first 7 days, is the key. If the patient within that window, you really need to monitor. Dysautonomia, patients are more prone for arrhythmias, all sorts of, so you need to treat them, so they need to be under medical care and close monitoring in order to get treated. And if they have bulbar dysfunction, they cannot swallow, so all these things very important. So you need to calculate the score, and if the score is high, obviously you need to admit the patient to the ICU, not the regular medical ward. Key point to notice. So what do you do? So after you admit the patient, the ICU is admission and followed by IV immunoglobulins. I will start with IV immunoglobulins and I'll see for 5 to 7 days. If the patient keeps on improving, that's well and good. The other options are plasmapheresis. But some hospitals, they may not have this facility. So start with IV immunoglobulins. It's very easy, better than easy availability, and always monitor the autonomic function, respiratory function, swallowing function, watch for cardiac arrhythmias. So early rehab physical therapy again is key for neuroplasticity, key for improvement. I have a patient, very young patient, similar, she presented the same way, and even though we gave IV immunoglobulins, she didn't showed significant response, but we were very persistent, keep on treating her with physical therapy and gabapentin, and now she's much better. When I see her walking to my clinic, without any problem, I feel like very happy. So you really need to pay importance to all these things. Okay, let's my clinical pulse summary of whatever you learned today. Stroke time is money, so please diagnose it, get the CT scan. If the patient is within the window, treat the patient with clot buster medication. What is the most common area of location of the stroke? Usually basal ganglia, putamen and caudate. Note that. And then the second one, with respect to seizures, you know how to manage the seizures. If the patient is not responding to the regular treatment, think of other etiologies, especially autoimmune encephalitis. Treat with IV immunoglobulins. Early immunotherapy is the key. Then the third one, Guillain-Barré syndrome, make sure the patient, examine the patient, preceding GI illness, absent reflexes, rapid progression, admit the patient to the ICU, close monitoring, and IV immunoglobulins or plasmapheresis. Now comes the exciting questions. I'm going to put these questions, and then whoever knows the answer, please raise the hand, and Dr. Krishnaveni ma'am will moderate all that. And let's see. Which of the following is the most common location of the cerebral larynx? Cerebellum, putamen, midbrain, and subcortical white matter. Who is ready to answer?
Subcortical white matter.
No.
Very good try. Thank you for trying. Next person. The clue is I just mentioned to you just a few minutes ago. Now it's easy. You have only 3 options. You already know one option is not right.
Option B, putamen.
Yes.
Exactly. Excellent. Congratulations.
Wait. Aim करने पर. What's your name? Prashant, you're from 2K21 or 22 batch? 21 batch. Maidling Rivan. One.
Hurry, take photo.
Okay, Harathi. Yeah.
Congratulations. Let's move on to the next slide. Putamen is the answer. As I told you, basal ganglia is the most common site. Let's read the second question. 72-year-old. Again, this I already mentioned in my presentation. With 72-year-old hypertension, atrial fibrillation brought to the emergency room by the family. When you look at sudden onset of weakness in the left leg, and then the patient is apathetic, and significant weakness in the left lower extremity when compared to the left upper extremity, and patient seems very uninterested, and patient has urinary incontinence. There is no aphasia or facial droop. Which arterial territory is involved?
Right anterior cerebral artery.
Oh wow! So you're really paying lot of attention to the lecture. Congratulations. I don't know your name. My hearty congratulations.
Yeah, Chandrika from 2K21 batch. 22 batch. Very nice. Saran. Sir, अपने पटको. Good.
So the reason is the only left lower extremity is more involved, and I did mention in my presentation urinary incontinence because micturition center will be there in that area, anterior cerebral artery area. Let's move on to the next one. Which of the following medications has been demonstrated detrimental to recovery in the early post-stroke patients? You have all those four options: sertraline, phenytoin, levetiracetam, hydralazine. I did mention about this medication that I did not. It's not my first priority. So now you know the answer.
Option 3.
Oh, I said that's my favorite. No, I said this is you should not give to early post-stroke patient. What did I say? That's not my priority.
Phenytoin.
Yes, exactly. And my hearty congratulations.
From? Sir, Ranganath from 2K22 batch. Naveen.
Congratulations, Ranganath.
Yeah, good. That's nice.
వాళ్ళు దూరంగా కూర్చున్నారు 22 బ్యాచ్.
So you should not give phenytoin and phenobarbital or first generation antipsychotics and benzodiazepines usually in the post-stroke. But you should be cautious unless you need it. You should not give them. Okay. Next, move on to the last two questions. Question number 4. Maybe this I didn't talk about it, but you can guess it. Which of the following types of arrhythmia is most common in Guillain-Barré syndrome? I said common. Okay.
Get up, Ray, Savar.
You can just try. There is a chance of 25% winning if you try because you have only 4 options.
Option A, AFs.
Oh, that's a very good try, but that's not. More simple. I think the more simple.
Long QT syndrome.
Oh no, you have 2 more options only.
Option 4, ma'am. Option 2.
You're only You are only left with one option. That's what I'm like smiling, you know. All the options are gone. Okay. Sinus tachycardia is the most, we always think about AV blocks, atrial fibrillation, long QT syndrome, but the most common arrhythmia that you see, that's why you should not rush yourself to treat it. Just keep an eye. That's why we need to monitor the patient in ICU. You should not rush. Okay. Next, sinus tachycardia. Congratulations. The last question. It's a little difficult question, but I did mention in my presentation about this. In a patient with GBS, which of the following CSF results prompts you for the evaluation of alternate diagnosis, which means it's not related to GBS. You should think of other diagnosis when you see this. So glucose of 70, opening pressure of 25, protein of 70, WBC of 90 cells. We talked about this albinocytological dissociation during my present, and I did mention about this.
WBC of 90 cells per mm cube.
Perfect. Perfect. Congratulations. What's your name?
Suguna from 2K21 batch, final year.
Congratulations, Suguna. You rocked it.
రండి సార్ నాయుడు గారు. Thank you, Harathi. Yeah.
Thank you, everyone. It's absolute pleasure, and thank you, Krishnaveni ma'am, Dr. P.V. Sudhakar sir, Sandhya Rani ma'am, and Maithili ma'am, and Naveen sir, and Subraju sir. And then I really thank you, Dr. JVS Garu, for giving me this wonderful opportunity. Absolutely, it's my pleasure, and thank you, everyone.
Thank you so much, ma'am, for the exhilarating session. And of course, the students have woken up and very excited for the quiz and the gifts. Thank you so much, ma'am, for that session.